Good morning, guys. Today I'll be presenting a case. There is a case presentation, and I'll be telling you what are the differential diagnosis for this case and how we reach to our diagnosis. So we have a 48-year-old female with the following complaint. She has vague abdominal pain on and off since 4 months. She was hypertensive. There was no history of fever, nausea, vomiting, burning, micturition, no history of diabetes, asthma, or any thyroid disorder. On examination, basically on local examination, nothing was found, no clubbing, paraedema, teres, or cyanosis. Pulse was normal, but BP, she was hypertensive, so BP was 140 by 90, and respiratory rate was also normal, that is 40. On systemic examination, respiratory system, cardiovascular system, GIT, as well as CNS, all of them are within normal limit. And on gynecological examination, she has a hysterectomy done due to fibroids, that is 4 years back. So on examination, when she comes for sonography, these pictures were found. This is nothing but the liver, and this is kidney. And on kidney, this structure was found. This is slightly hyperechoic with some hypoechoic components within. And in the next picture, we are able to see this lesion only with hypoechoic areas. Measurement was taken like this with some hypoechoic areas, and the distance was come to 9 into 6 centimeter. So by seeing these images till now, we know that our lesion, which is well defined, not irregular, not ill-defined, it is very well defined. It has more hyperechoic components, and hyperechoic component generally on USG is fat and some hypoechoic areas as well. When we put Doppler, we guess that hypoechoic areas are taking vascularity. That means this mass lesion consists of some vascular component as well. So a mass lesion, till now we know that as a mass lesion on kidney, which has more hyperechoic components like fat and some vascular components, and fat component is more. Then we follow the patient to the CT and we get some images. So this is a CT scan, a non-contrast image, and this one is an axial section. This is also non-contrast image, but it is a coronal section. What we are seeing in this picture, that this picture consists of a well-defined round to oval shaped mass lesion. Kidney is not seen here, bilateral kidneys are not seen here. These are the bowels, and this is our vertebra. This is our muscle. These are the muscles, and this is bowel, this is bowel, this is bowel, and the subcutaneous tissue here. What we are seeing, that this is a mass lesion, round to oval shaped mass lesion with some hypodense component as well. And this HU, when it was found, that HU was nearly minus 80. So what is the thing which has minus 80 HU? That means it consists of probably fat. So a mass lesion with most of the fat components, which is mostly fat component with some hypodense areas within. And on coronal section as well, what we are able to see, that this is liver, these are bowels, this is our IVC and aorta, this is the mass lesion. Kidneys are not very well seen here because the section is on the upper side. These are our femur, iliac bones, and pelvis region. This is not in the pelvic region, means it's above it, and these are our bowels. This is the spleen, this is the stomach. So we are seeing that below the liver it is arising, and when we see the axial images of this, and basically is a contrast scan axial, this is arterial phase and this is venous phase. We are seeing here that the mass is arising, and the kidney here, the left kidney is very well seen, so it is arising near to this right kidney. Again, a well defined round to shade oval shaped lesion with some hypodense areas with it, most probably fat containing lesion. Here it is. And when we see on the venous phase, we are seeing that is a heterogeneously enhancing well defined round to shape oval region, which is heterogeneously enhancing, because we are able to see that some areas are able to take contrast. So heterogeneously enhancing, to solid components are taking contrast here. Venous phase we can detect it from the kidney and this. So on the venous phase we are able to see the bowels, the vertebra, these, and the mass is heterogeneously enhancing with fat components here, and some solid components are taking contrast as well. So till now we get to know that we have a mass on USG which consists mostly of the fat and the vascular component arising from our right kidney. And on non-contrast we have seen that a well-defined round to shape oval lesion which is predominantly hyperdense with some hypodense areas predominantly hypodense areas with some hyperdense areas as well. And on contrast we are seeing a heterogeneously enhancing mass, solid components taking some solid component taking some contrast enhancements, and basically the fat HU is -80. So predominantly it consists of fat. So what are the differential we are getting? That a mass arising from the kidney, mostly of the fatty component, some vascular component as well. So our differentials include, first, renal angiomyolipoma. The second differential we have is RCC. Third component which has lipid, that is the retroperitoneal liposarcoma. Fourth component is oncocytoma, a mass arising from the kidney, Vince tumor, and adrenal myelolipoma. Now I will tell you that why we are considering one differential more than the other. What are the positive for one and negative for other? Till now we know the history that we have a 40-year-old female which is hypertensive positive, which is hypertensive 140/90 BP. Okay. So let us first discuss about renal angiomyolipoma. Renal angiolipoma, what is it? It is the most common benign solid renal lesion. Renal lesion here arise from the kidney, and here we are seeing our kidney, it is arising from the right kidney. It is the most common fat containing lesion of the kidney. On USG we have already seen that hyperechoic areas were seen, and on CT we have seen that some hypodense areas were seen. So it was also fat containing, and renal angiomyolipoma is also fat containing. The majority of angiolympomas, they are sporadic, that is 80%, very well known, they are sporadic, and they are typically identified in adults. Okay, our female was nearly a 48-year-old, so it was that. And mean age of presentation is 43 years with the female predilection. Okay, our female is 48 year and she is a female. Fine. Female is to male ratio is 2:4:1. Okay, one thing to know about that. Okay, female ratio is higher than male ratio. Since most of the renal angiolipomas are sporadic, 20% are associated with syndrome as well. And what are the syndrome? That is, first is the neurofibromatosis. They can be present in neurofibromatosis, and they can be seen in von Hippel-Lindau syndrome as well. So sometime when a patient comes with some neurological features as well, which are present in the neurofibromatosis type 1 have optic nerve glioma, 2 have schwannomas, and other features as well. So but in our case, our female have CNS within normal limit. So might be the sporadic case. Okay. Clinical symptoms in a case of renal angiomyolipomas, patient can present with spontaneous retroperitoneal hemorrhage, because renal angiomyolipoma, that means angio has vascular component, myo has muscular component, and lipoma, that means it has fat component. We know from USG that our mass lesion consists of fat, it consists of some vascularity. So name itself suggests a mass lesion arising from the kidney which has fat component, muscle component, and vessel as well as vascular component can be renal angiomyolipoma. But conventionally they can present as a spontaneous retroperitoneal hemorrhage. Why spontaneous retroperitoneal hemorrhage? Because of their vascular component. If the patient is hypertensive, there is high likely chance that these renal angiomyolipomas in them some vascular component can burst and they can present a shock. And what is that known as? That is known as Wunderlich syndrome. In Wunderlich syndrome, what happens due to this spontaneous retroperitoneal hemorrhage, the patient will land up into shock, which is associated with Lang's triad. What is Lang's triad? Lang's triad is flank pain, flank mass, and shock. You can remember it with FFS. Flank pain, flank mass, and shock. Okay. A patient can present as a mass, okay, flank pain again, flank pain, flank mass, and patient can also present with UTI because the mass component is there. Some function will be altered. UTI can be present, hematuria can be present, patient can present with renal failure, and patient can present only with hypertension, or patient has hypertension only. And in hypertensive patient, there is very much chances that spontaneous retroperitoneal hemorrhage happens. So that treatment is basically that the person's BP should be within the normal limit, so that spontaneous rupture of angiomyolipoma does not occur and patient will not land up to Wunderlich syndrome or the Lang's triad. Okay, so usually on ultrasound what we get in renal angiomyolipoma, hyperechoic lesion. Okay, in RUSG also we are able to see hyperechoic lesion, usually located in the cortex and have some posterior acoustic shadowing. Our lesion is just creating a mass effect. We have seen that on CT it is creating a mass effect. It is displacing IVC a little to the left. Okay, on CT features, what we are able to see that most lesion involve the cortex and demonstrate macroscopic fat. Very important thing here that it demonstrate macroscopic fat less than -20 HU. Okay, our lesion when we have able to see in CT that it has macroscopic fat. Fat component was so much, hypodense areas were so much, and the HU was -80. Okay, less than -20 HU, -80 HU was there. So macroscopic fat was there, and presence of macroscopic fat is very important to characterize that our lesion is angiomyolipoma. Second most important thing here is written is absence of ossification and calcification. Yes, absence of ossification and calcification is very important, because if there is ossification and calcification, it will favor more towards RCC. Okay. So what is RCC, or the renal cell carcinoma? Renal cell carcinoma is basically macroscopic fat in RCC, but with ossification and calcification. Usually macroscopic fat is not present in RCC, but if sometime it will present with ossification and calcification. They are irregular tumors, are very well defined tumors. Renal angiomyolipoma usually invade the cortex. Here sinuses are involved. It includes more of the necrotic component as well. And the focal or diffuse signal loss in opposed phase suggests microscopic fat, in contrast to the curvilinear Indian ink artifact seen with macroscopic fat, which is very common in clear cell RCC and less common in fat poor AML. AML is angiomyolipoma. Angiomyolipoma usually characterized of the fat. Okay? But in fat poor AML, what we are seeing, we are comparing here two things. One is the clear cell RCC, another one is the fat poor AML. Both are the different entities of their different entities. Like in AML, we are considering fat poor AML, and in RCC we are considering clear cell RCC. So here what they are saying, in contrast to the curvilinear Indian ink artifact seen with macroscopic fat. So they are saying that focal or diffuse signal loss in opposed phase suggests microscopic fat. Microscopic fat is common in clear cell RCC and less common in fat poor AML. So if microscopic fat you are able to see, then you are more probable to the diagnosis of clear cell RCC. Okay. So what we are seeing in this picture, this is an axial section, CT, contrast enhance. We are able to see that this is our left kidney. These are the vertebra, aorta, muscles. These are the muscles. Some bowel components. These are the bowel. This is the other kidney, or no, and this is some part of the other kidney, some sinuses you are able to see here, the cortex portion, and then you are able to see an irregular lobulated mass. It's an irregular lobulated mass, and these are some calcification, and it is heterogeneously enhancing mass. So a heterogeneously enhancing irregular mass arising from a right kidney with some calcifications. What it can be till now what we have understand, okay, calcification and ossification is more favoring towards the RCC. So this basically serves, if our lesion looks like that, which have some ossification, calcification, our diagnosis will favor more towards RCC. But in our case, was it an RCC? Was you able to see any calcification or any ossification? Was the mass a little irregular? No. So here our mass is not probably in RCC. Till now we know that it can be an angiomyolipoma, but it's not an RCC. Although our radiological diagnosis are always not confirmatory, we should have to have a histopathological diagnosis. But how we can go towards certain diagnosis, I'm trying to tell you like that. Okay. Third differential, we have retroperitoneal liposarcoma arising from the retroperitoneal areas. Why retroperitoneal liposarcomas? I'm showing you a picture how should a retroperitoneal liposarcoma should look like. So this is a contrast enhanced CT image, axial section. We are able to see the kidneys here, one kidney, the other kidney is here. This is the vertebra, these are the ribs, some of the bowels. We are able to see a well-defined, a very large mass, well-defined large mass, which consists of some hypodense areas and some hyperdense areas. So these areas are basically the fat component and soft tissue components. Okay, fat will appears hypodense and the soft tissue hyperdense compound, and we are able to see that these fibers or these soft tissues are creating some septation in between them. So multiple septa will be present and soft tissue component will be enhancing. So what they are trying to tell here, if it is retroperitoneal liposarcoma, fat is present in AML also and fat is present in liposarcoma also, but because it is sarcoma, soft tissue component with multiple septation should be present there. Was it present in our case? No, it was not present in our case. So our diagnosis is probably going towards AML till now. Okay, next is the oncocytomas. Oncocytomas are relatively benign renal tumors. Okay, AML is also a benign renal tumor. Main clinical importance of this lesion is the difficulty in pre-operatively distinguishing it from RCC, as epidemiology, presentation, imaging and even histology can be similar for oncocytoma. Suppose I am telling you that our lesion was oncocytoma and we have a differential in our mind of RCC, but they are kind of very similar. Epidemiology, presentation, imaging and even histology of both them is very similar. So we should see on our imaging that is it an oncocytoma or what favors oncocytoma more than RCCs. Okay. So this is an axial section on contrast CT scan image showing this is the right kidney and this is the left kidney, and we are seeing left kidney is looking like little bulky and there is a mass lesion arising from the left kidney. Okay, this is the liver, this is the pancreas, some bowels are seen here. Okay, this is the aorta, this is again liver, okay, and muscles, these are ribs, muscles, subcutaneous fat, and here we are able to see that our left kidney, a mass is arising which is very well defined, enhancing mass with a central stellate scar. Stellate scar we are able to see. So this central stellate scar is very pathognomic of our oncocytoma, usually present in nearly 30% of cases, which helps with distinguishing from RCC. Okay, so till now we know that our lesion does not consist of a central stellate scar, so it was not an oncocytoma. Wilms tumor. Wilms tumors are the tumors of the kidney, but they are basically found in the child. Our patient was 48-year-old female. There it is CT axial section, contrast scan. We are able to see a right kidney, a left kidney, a well-defined mass arising from the left kidney with heterogeneous enhancement, both homogeneous hypodense and hyperdense areas. So it is a heterogeneously enhancing mass arising from the right kidney. It was supposed to be a Wilms tumor, but since they are present in more commonly in childhood, so our mass was not in the childhood, so most probably it's not a Wilms tumor. Next is adrenal myelolipoma. We consider 6 differential diagnosis. Adrenal myelolipoma should arise from the adrenal gland. Here we see that this is the left kidney and adrenal is above them, and we are able to see a well-defined round-shaped lesion which is hypodense, which is mostly hypodense. Okay, since it is in contrast scan, we are able to see from here it's heterogeneously enhancing more of the fat components but arising from the adrenal gland. So it is adrenal myelolipoma, not an AML, angiomyolipoma. So thank you. Till now we get to know that our mass is more toward angiomyolipoma, because 48-year-old female was there. She was hypertensive, plus the fat component is very well seen on USG, some vascular component as well, no central stellate scar, no irregular margins, no calcification, no ossification, not a child, okay, not arising from the adrenal as well. So finally, a differential diagnosis favoring our most probable diagnosis, that is renal angiomyolipoma. So this is a case discussion of a renal angiomyolipoma. Hope you get something from it. Thank you so much.